our next talk. This time we have Pat Healy, the National Director for Social Care with the HSE, and he's going to tell us something we probably all, well, not all of you, but some of us might need to know how to access the service.
Thanks indeed. And thanks, Chair, thanks members of the Assembly for giving me the opportunity to talk to you today. I think it's really important work you're involved in, and I appreciate that. And maybe taking up Michael's point there about images and so on, this is a slide I've used in various presentations I've done when we look at opportunities and challenges, and what the Chair was saying earlier about focusing on opportunities maybe more than challenges. I was struck by in the context of the issue of ageing and our perception of older people and ageing, I'm struck by climbing Everest. And we've just come at the end of May to the end of the season for climbing the mountain. And the Times were covering it during the period this year, and a number of Irish people did it successfully. But I was struck that there was a big issue about, I think the record is an 88 or a 90-year-old has actually climbed it. And the person who had lost the record went back to try and climb it again and actually died in trying to do that. And it just struck me that it totally changes your perception of nobody. When they think of it, they think of people going up there like those lads and lassies with all the gear and so on, and you don't think of 88 and 90-year-olds climbing Everest, but they do. The other piece of it is more from our own side of it in terms of the health service and others around managing for the future and so on. I think if you want to climb Everest successfully, it takes a huge amount of planning, a lot of coordination and significant teamwork. And I think those are themes that you'll see throughout the presentation that I'm making around current access, problems with access, and what we're trying to do in the future. So I think I just wanted to make those points to begin with. And just this in terms of benefits of ageing, again, around perceptions and so on, the notion that you had the President Mandela there in South Africa taking up his job at 76 after a huge struggle, and then the transformation he played in that society. Or again, if you look at our own T.J. Whittaker, and he keeps coming up in surveys as to be one of the most well thought of public servants and contributors to Irish society. And again, just the notion of ageing and sometimes how we can be ageist in that, or how we can set limitations ourselves as to the opportunities that exist. And perhaps then moving into the services, the way we shape our services in order to respond to the aspirations that citizens actually have. So what I'm going to just focus on is, as the Chair said, I circulated a paper which goes through a lot of the detail and so on. So I'm going to try and deal with maybe just some of the key issues that are worth mentioning, and we can always deal with more detail in questions later. But first of all, the key focus around, I suppose, community services and what are community services and so on. And I want to touch on that, and particularly two ideas of a continuum of care to support people through the life cycle, including ageing, and this notion of integrated care. It turns up a lot. It's in, where it's identified as something that we should be doing, and I just want to talk a bit about that. And if you want to implement integrated care, which seems to be an international indication now, evidence-wise, well, what are the kind of organisational structures you should have to do that? And I want to touch on that and talk about primary care teams and networks as we do it. And then just to talk about the specific services that have been mentioned and how we access them and some issues around that. And to move to the area then of opportunities and challenges maybe, and some of the points that I think are worth mentioning if we are to move to the location that we want to move to, and finish with what we're calling NORA's story, and I'll explain that at the time. So maybe just on community health services. So in Ireland we tend to have a love affair with our acute hospitals, and everybody is aware of those. But I suppose community healthcare services is everything outside of an acute hospital. And that's what we talk about when we talk about community healthcare. And I think it's also about from childhood through to adulthood and into ageing and death and end-of-life care. And it's about the health services that are provided either directly by the health service executive or often by voluntary or other organisations on our behalf and funded by us. And I think a key thing then is this view, particularly as we look at the issue of ageing, that people as they age want to live in their own communities. And as well as that, I think that's a key piece. So how do you develop sustainable communities? What does that mean? And the other thing is People report to us all of the time, and I'm sure you've all heard it well, about that they find navigating our system very difficult. So there are two real challenges, and I think the fundamental part of what we're trying to do and are doing is, I think, the notion of community and developing sustainable communities in the old sense of the word, of enabling people to support their own and to provide resources, but also different approaches in order to do that. And so I'll just touch on this idea of the continuum of care. And I've talked about it in the paper that I've done. And I think I just want to break it into a couple of different segments, if you like. So, as Michael said, there's about 4.5% of people actually reside in long-stay care, but that means that there's 96% of people actually living well. And we tend to focus on those in residential care, whereas actually the whole issue of health and well-being and supporting communities should be about enabling people to live in their own homes. And in that first part, that's what we try to do. So it's about participation and inclusion. As an organisation ourselves, we're trying to support a whole range of volunteering organisations at local level to maintain and support people to live within their own communities, and also to develop the kind of knowledge and access and so on that people can do that. When you move into the second sphere, they're over 65, but requiring some service. Obviously, as people age, they will require some additional service, and that tends to be the core of our community service then. General practice, public health nursing, and things like daycare, social activities, meals and wheels. Beginning home care, home health services tends to be the floor, and people will get a few hours in order to get up in the morning, get their lunch, put them to bed in the evening, that type of thing. And all of that is, the idea is that it will be accessed through your primary care team, the GP, public health nurse, and so on. If you move on to the more, I don't know what colour that is, yellow maybe, you move in then to the more specialist side of it. As you require more specialist input, people might have a bit of heart failure, some dementia, they might have diabetes, arthritis, and so on. Multiple needs as they age, you require a higher level of support. That's where the home care packages that Michael was talking about come in. That's where things like supported housing and care of the elderly support, short stay beds like respite care, which support families and carers as much as they do the individual. But also, again, then where you need more than just a specialist, you might need to see a geriatrician or others. And that's that, and that's one of the key resource utilisers in our system. And then finally, end of life care, as Michael talked about it, and the issue of long-term care. So our agenda and our wish is that end of life care, and more importantly, long-term care for nursing homes, should only be that end of life care. So you should, insofar as possible, support people to live within their own community for as long as possible. And if you're to do that, all the evidence talks about this integrated care, joining up care. So what exactly does it mean? And I think it's about, in simple terms, the idea of individuals and staff working together in a well-coordinated way to respond to the assessed needs of the individual that you're supporting. And I think there's two things in that, and Michael touched on this. I know Diarmaid O'Shea would have talked about it this morning. The issue of quality outcomes and whether we're measuring the quality outcomes, and the other is the ease with which people can actually access those services. And the view, again, as I said, is that people find it very difficult to access services. And all the international evidence indicates that implementing this integrated care for older people is difficult. No one in the world has cracked it fully. Huge amount of work has been done in Scotland, and we've been learning from that. But much of what we're trying to do at the moment is centred on this idea of better coordinated care, linking better with people, listening better than we do, and translating that into an integrated care model that will work for people. And the key thing is to put the person at the centre. So that's the idea. That's what we're trying to do. We've learned that one model doesn't fit all. It's a journey and not a process, or it is a process. It's not an event. You don't fix it straight away. It'll take 10 to 15 plus years to do that. It also poses challenges of leadership, and on the top left there, it poses challenges around professionals actually working differently, because they tend to be used to work in silos in their own specialist area. And so you have to try and work away from that. So then that tries to bring us, if integrated care is the way to go, and if we want to develop better coordinated care, we want to put people at the centre of it, what kind of a structure do you put in place to do that? And again, I've put more detail in this in the slides and put links to it, but just to talk about this for a minute, essentially, I chaired and led a group to look at this back in 2013 and into 2014, and government accepted it, and we're rolling out this now, and there are now currently 9 community healthcare organisations in these geographic areas, each with a chief officer, each with a new management team based on around primary care, social care, mental health and so on. But I think the fundamental thing is that idea of trying to provide the right service at the right time in the right place by the right team. And the key, while it looks geographically spread there and so on, and the idea was to have it big enough that it could justify the investment of the business supports like HR, finance and all that, the IT systems that go with it and the staffing, management structures and so on. But much more importantly is this idea of the 96 networks. So below those organisations, there are 96 networks, each led now by a professional who's responsible for delivering the primary care services and with a role to integrate these other services like older people, disability and so on. And for the first time in Ireland, you'll have that one key individual, you'll have general practitioners working with those people, and the idea of establishing a key worker to try to support people to navigate the system, as I talked about earlier. So what that's about is trying to make it simpler for people to access the system. And we started to roll that out across the country. And the other key piece, and Diarmuid may have talked about this morning, is the idea of a primary care team. So the network would be a population of about 50,000 people. That's about 5 primary care teams of 10 each. Each of them would have a few GPs, dedicated public health nurses and specific staff so that they could get to know the population that they're dealing with. And when you're dealing with 50,000 population or 10,000, I think it's small enough that you can actually work with that. Of that, about 10 to 15% would be older people, and of that number, about 10 to 15% will have high needs. That's about 500 or 600 people in a network that require high support in order to maintain them in their community. So moving on from the structures that we're putting in place to try to support that, we'll talk about access then. And again, I've set out in the paper specifics in relation to what we're providing, but I think there's a couple of points. You'll have got population data this morning. Michael has dealt with more there, but I think it's a figure here on the left in terms of population. I think 2 things that really jump out. One is the increase in life expectancy since 1993. Increase of 39%, but the other really significant figure is that by 2026, 100% increase in over 85-year-olds. So this is something that we can't not plan for. This is something that we have to deal with because it is coming at us in any event, and it's important if the citizens that are growing and going to be ageing this way, if they are to have the type of service they want, we have to develop a structure that will support them. Equally, the access issues there, I've talked about some of the people who are familiar with admission to acute hospitals and so on, but in dementia there, 50,000 people in the country currently with dementia, but that's going to grow to 100,000 cases by 2026. So again, this is something that's real and live and that we have to deal with at an urgent level. So on the right-hand side, what's the kind of resource that we currently have today across the various headings we've talked about? So both myself and Michael have written in our papers about the nursing home support scheme. There's a standardised assessment, there's a financial system, and you gain access to it. And currently there's €940 million. We spend in Ireland about €1.5 billion on services for older people through the health service. 940 million of that is dedicated to the nursing home support scheme. So as Michael says, we have in the country a vision and a value system that says we should keep people at home, but effectively 2/3 of the resource that we're applying is based on residential care. In terms of home care then, again, as Michael said, there's not an established scheme for home care as there is for the nursing home support scheme, so it can be inconsistent in terms of its application. 16,500 around people receiving home care packages, and 3 million spent on that overall between home care, home help and home care packages. Another area then, transitional care I'm calling it. It's like short stay beds. All of you will know community hospitals in your local area, and they all have respite beds, convalescent beds, and they support people to get a break. They support the person to be seen by some professionals, get a bit of respite and so on. And in that, We provide, there's about 2,000 beds, 1,918, and we provide about 152 places a week to the acute hospital system for people to move out for convalescent and step-down care. So that gives you a sense of the resource. Is it adequate? No. Does more need to be done to support that? Yes. Are there waiting lists? Absolutely, and I'll talk about some of those in a moment. And so rather than going into detail on all of those, I thought it would be worthwhile just taking home care as a specific issue to give you a flavour of some of the issues in dealing with that. So taking that a bit more in more detail. In 2017, these are the figures: €373 million, 16,500 home care packages, 10.5 million hours of home help, 49,000 people receiving that. But the average, as we've set out in the paper, is around 4.5 hours per week. That's the average. So some people can get 20 hours. That means some people are only getting an hour or a half an hour. So on average, it's 4.5 hours for 49,000 people, and that's the level of resource deployed. And while we have deployed that resource, and while we have got more resource in recent years, there's still 2,200 people waiting for home care packages and 2,400 waiting for home help hours. Some of those are people who already have a service but need more, and some are new people because of the growth in the population who now start to have an increase in the need. So it gives you a sense of the scale of what's being done. And as I say, do we have enough? Absolutely not. We are clear we don't, but we're trying to do the best with what we have. But then just to translate that, if you were to offer a single additional hour to all those who currently have it, it'll cost you €51 million at an average cost of €20 an hour for a standard hour. And obviously part of what we're doing, a part of the additional cost that we have, is that in order to facilitate people, you need weekend support, you need support in the evenings, and obviously the cost of those hours are more costly. And so you need a more flexible service, you need a service that's developed to meet the needs of individuals and families, and therefore there is a strong case, and I'll talk about it again later, about developing a specific scheme for that, but we don't have one currently. So that's just talking about the particular services. So having looked at that, I'd reiterate, and it's very similar to the point that Michael made. The quote here is from our Director General, who made a submission on our behalf from the Health Service to the 10-year committee, Roisin Shortall's committee in the Oireachtas. And basically what we were clearly saying is that there has to be a shift in the balance from the acute hospital system towards community, and that's both primary and social care. And to try, if we're to make it meaningful, that the type of networks of 50,000 that I'm talking about there, if they are to be meaningful and support people, you have to provide the resources at that level, and you have to engage with people at that level, and you need to devolve decision-making further down to that level so that the general practitioner and the nurse and the therapist who know the people are involved in shaping the decisions with the family and the older person into the future. So what are the kind of things that are going to have to be done, and to give you a sense of what's required in order to do that? So a standardised assessment tool, we've implemented that in order to implement a standard system across the country. And it's worth just talking about that for a minute, and I just want to look at that. It looks like a complicated slide. But what we're using is people like Diarmuid O'Shea and others worked with us to actually identify what would be the best assessment tool a number of years ago. And what was decided was this one, Inter-Ray. And that's used, and I've just shown, right across the world, in Europe, North America, South America, and Middle East, and so on. And on the right-hand side, what's really beneficial about that, and I think it's important from the Assembly's point of view, it's not just a medical focus. It actually takes account of the needs of the totality of the person and the environment that they're living in. And what we will have as we roll this out is that our professionals at local level will have handheld IT computer systems that they'll just call, meet the person, sit down with them, do the initial assessment that will take about an hour and a half, and after that you would have that. You'd have that for good, for the time of supporting the individual, and even if you go to hospital or anywhere else, you'd have access to that data, and that's very positive. And from then on, visits of quarter, half an hour can update that so that you can use that data. And one of the key things to do with one is to standardise it, but the second thing is that everybody who has higher levels of need should have a care plan that they're involved in shaping, and that with themselves and their family, and that's worked out through this standard assessment tool. And the third key thing about a standard assessment tool is that it also links you to resource allocation. So when an assessment is done, you should be able to shape a care plan based around a discussion with the family and the individual, and to resource that, identify the cost of it. And that's the type of planning that has to go on. Work is underway already. We've rolled this out in a number of Tala, Beaumont, Cork, Limerick. There'll be 20 of our major locations around the country where this is rolled out by the end of next year, and this is something that's continuing. So that's to give you a sense of that type of work has to go on to beneficially support people at local level. The other is this issue of an integrated care programme. And Diarmaid O'Shea, I know, would have talked about this morning. Diarmaid is working with us on it. But some years ago, a view was taken that everyone should get together, if you like, across all disciplines. So surgery, they've developed a standard way of implementing surgery across the country. Acute medicine have done the same acute medicine programme. In the same way, we want to develop an integrated care programme and agree how that will be implemented across the country. So we've set out a 10-step programme. There's a consultant geriatrician, Siobhan Kennelly, with Michael Fitzgerald, who's the head of operations, who works with me, and a project manager, and a very comprehensive team and subgroups around the country who are working on this and working to implement it. And so the kind of thing I was talking about structures, about those networks, and about the type of resourcing and single assessment tool, it's to make this real and to have all of the professionals involved working with local communities to implement that across the country. That's the idea. It's only beginning. We have, as I say, 20 sites where all that is being rolled out currently. But I draw attention, and I don't intend to go through it all, but item 2 here, the population planning side of it. It's really important. Because 20% of the people, when you carry out assessments or meet with them, they don't need significant service. They're living happy at home, they're all walking, they might be climbing Mount Everest. But then, as you go through that, as people age through the life cycle, they will require additional supports depending on what their needs are. And one of the things we want to do is that as you require more complex needs, that a case manager would be assigned to you, and that it would simplify things for the individual, so that the responsibility for trying to navigate the system would be removed from the individual, and that there would be a case manager to support you, whether you're going into the acute hospital or whatever, into the community, meeting your GP, and to manage that and the care plan. So that's the type of approach that's envisaged in implementing the framework for older people. So go back then, I think, to a very important point that Michael talked about, and just to take a while to talk about the home care. Because clearly, as you've seen, Minister has made announcements, Minister Harris and Minister of State McEntee, that the department, we've been working with them on it, will be leading a consultation process now on the establishment of a home support scheme. Similar, I use the word similar in inverted commas, you know, a scheme that will be a standard statutory scheme, like nursing home support scheme, is for residential care, but they're not saying that that's the kind of scheme it's going to be. They will consult with people and work out. It'll have to be a tailored scheme that sets out how home care is going to be statutorily provided with eligibility guidelines right across the country, and they're going to start that. And I would suggest that it would be important that yourselves as an organisation or as an entity now would contribute to that, because I think it'll happen during your time, and it would be very beneficial to get a kind of a submission to that consultation from yourselves, I would think. A really important part of it is that it has to be well resourced. I've given you an indication of one additional hour to the 50,000 people who currently get resources cost you 51 million. So it has to be resourced. But more importantly, it will also have to be simplified so that people can gain access to it. One of the complaints about the nursing home support scheme is that it's very complicated. And so we'll have to try and keep the scheme simple, make it easy for people to access, make it easy for professionals and families and others to engage around it, and not to make it too complicated. It will still have to be a statutory scheme. And I think the key thing of regulation is really important, because that issue of quality and outcomes, there will of course be a necessity to have proper regulation, and that will take a couple of years to implement, and we've started to prepare for that already within the health service. So I think this area of the home care is going to be a very significant additional area, but it is not the only one. We've talked about long-term care. Not a lot is, not sufficient is done about rehabilitation and convalescence. So we don't have an effective rehabilitation strategy or plan in Ireland. So we have the National Rehabilitation Hospital, and we have plans for that level, and it's being developed, and in fairness, significant resources being put to it, and the intention is to have 4 regional hubs and so on. But I'm talking here more about the local level, down the community hospital type level, where slow stream rehab or access to a geriatrician and a team with physio and OT is easily accessible in those 96 networks that I talked about earlier. So that at local level, people get to know the geriatrician they're dealing with, they get to know the professionals and the GPs and so on, and so that the decisions you're making about mom or dad or brother or sister is centred around professionals that you come to know and are specialised in the area of rehabilitation. That's really important. And I would also say that I would agree wholeheartedly with Michael's point about sheltered housing and alternative means of supported residential care. So I think a very positive thing in Ireland is that social care is part of the health service because it's integrated with it. You see all the issues going on in Britain at the moment with social care as part of the local government, healthcare as part of the NHS, and it doesn't integrate very well. In Ireland, social care is integrated with the health service, but it's not linked effectively, as Michael says, to local government. There's a really good piece of work going on in Dublin at the moment, and in some other locations, but just given we're based in Dublin, a really good piece of work going on here, linking alternative housing models with the work we're doing in health, and I think that that's something that could be used as a pilot without going into the detail of it for the future. The other key piece is the issue of dementia-specific care. And as we are developing residential care, we currently have a €500 million programme to bring our current 129 public units up to the standard for HICWA compliance by 2021. So that's going to take the current level of units to get up to that level. We are going to have to develop more dementia-specific units with the appropriate support and engagement in relation to those, and that's an area that a lot more needs to be done if we're moving from 50,000 people with dementia today to 100,000 people at that estimated by 2026. And so the issue then of supported choice, and I put in there the issue of assisted decision-making as well, and I see Patricia Reichart-Clark down at the end of the room there, and Patricia is a far more expert individual than I in relation to assisted decision-making. I've covered it a little. We are currently working with a group of people. We are taking advice from people like Patricia in relation to preparing the health service for this issue of assisted decision-making. But what I do want to touch on is what does it mean for us fundamentally, and the issue is choice is what I want to just touch on. And the issue of choice and this issue of community and using the assets in the community to support people. So in relation to this idea, it's a big co-production is a word that you'll hear a lot more of now. But essentially what it is about in the health service, I think we all know and we've learned, we don't spend sufficient time talking to the people that we're serving, or listening, or hearing the choices that they want for their futures. And if you relate that back to what I was saying about nursing home care, we have a particular model of, not nursing home care, sorry, home care, where we provide care in a particular way. But what you'll see is a lot of private care is being purchased at the moment for a very different, broader range. So people use private home care to go out and buy the messages. They go out and they do, take a break or watch a movie, and they get someone in to babysit, in effect. So I think there's an issue about us developing our services in a much more tailored way to meet the needs of individuals. And I think the issue of the assisted, the new legislation will force us to move in that direction. And I just want to put that on your agenda about the issue of what I'm calling co-production, that we really need to engage with communities and involve communities in decision-making around health service provision and health service resource allocation. And I think the model is there to do that now through these 96 networks that I talked about earlier. The last point there is this issue of individual assets a big way of putting it, but basically, when we engage with communities, we don't always utilise the full resource that's there. I was talking to a colleague of mine this morning, and he was talking about bringing his mother to a tea dance in Killarney later this evening. And they're going to go to a GA event later on to watch a match. And so the thing is that type of normal living and support and activity that goes on should be embedded as part of our health service provision, or we should take account of it, and we should take account of it in a much more real way than we do currently. And I think that's the idea that I have and that I've been talking about enabling local communities to support their own people. And I think that's an important piece. So they're the points I wanted to just bring you to, and that brings me finally to NORA's story. And so what we want to do here is just all that I've been talking about there. What does it mean in real practice what would it mean for a NORA in Ireland who's ageing and who has complex needs? And what I'm trying to do here is give you a flavour for a short video of what it would mean in order to, if you implemented all that I was talking about just there. And I think the intention is that we would kick that off. Yeah? So thank you for the opportunity. And I will try and... Oh yeah, here we go. Thank you for the opportunity, and I can deal with questions later in the day. There we are. Thank you.
In Ireland, as in many other countries, we are living longer and better lives. This means we have to make changes now to ensure we can provide well-planned, well-coordinated care for older people when and where they need it. This is Nora's story.
Hello, I'm Nora. Until recently, I was living on my own and was managing well, despite a few health problems. I'd been living there my whole married life. I'd friends in the neighbourhood, and my daughter lived near enough. I'm 85, and my husband died a few years ago. After that, I did start to have a bit of trouble managing around the house. If I'm honest, I felt I was getting a bit forgetful at times. About a year ago, I had a fall at home, and my daughter called the ambulance, and I had to go to hospital. I was checked over and returned home quickly enough, but while I was still getting over that, I became sick again with an infection. My daughter started to stay with me more as I wasn't sleeping well. She also helped to make sure I took the right tablets. I was supposed to get home help and see a specialist doctor for older people, a geriatrician doctor, I think. This was taking a long time, and while I was waiting, I had another fall at home. And this time, I broke a bone in my pelvis. When I got off the trolley and into a hospital bed, between the jigs and the reels, it took a long time to see all the people I needed to see. Therapists, social workers, and every ologist under the sun. To cut a long story short, I ended up in hospital for weeks. I tried my best. The nurses and the staff took good care of me, but it was tough. It was noisy, which kept me awake at night. And I was in a busy ward with people of all ages and stages of life, coming and going with all sorts of problems. I had to keep repeating my story to the nurses and the doctors. I was in pain, too sore to move round by myself. I got lonely and was upset at times. I hated that I couldn't do normal things or take care of myself. I just wanted to go home and get back to myself. But eventually, the doctor decided I needed a nursing home, and that's where I am now.
Here's how Nora's care might have been better coordinated. Evidence shows that if we identify older people at risk earlier and coordinate services better, we will reduce longer hospital stays and avoidable long-term care. In doing so, we will enable older people to stay at home longer. A key change is that we take a long-term approach to anticipating and coordinating older people's care rather than reacting to their needs as a separate episode of care each time they present to health and social care providers. There are many examples of good care evident around Ireland. GPs and pharmacists undertake reviews of medical and pharmacy needs every day. home helps assist older people who need help with everyday tasks. Public health nurses monitor people's health and social needs on an ongoing basis. However, the problem is that even when these services are available, they are not sufficiently coordinated by a named person who is dedicated to working with older people and who can act as a point of contact that anticipates, plans and coordinates care with the older person and their carers. NORA would have benefited from the care and support provided by a primary care team who could have carried out an early holistic evaluation of her health, including her social care needs. This would involve a multidisciplinary team assessment by professionals trained in older persons' care, such as an occupational therapy assessment to suggest modifications or aids to her home, physiotherapy to assist with walking, social workers to ensure supports are in place to keep her involved with her community. The primary care team would link with a specialist geriatric team if and when required. To coordinate her ongoing needs, NORA would have benefited from a case manager for older persons, who would have worked with NORA and her family to develop a care plan to meet her needs. This person would act as a point of contact and coordination, who helps NORA to access services early rather than waiting for a crisis to happen. If acute inpatient hospital care was needed, steps could have been taken to improve the likelihood that NORA would have returned home. These steps include a comprehensive geriatric assessment led by a consultant geriatrician and multidisciplinary team at the time of her admission. Admission to inpatient care on a specialist geriatric ward with a healthcare team familiar with managing complex healthcare needs in older people and with access to rehabilitation. And clinical staff with specialist older person knowledge, such as advanced nurse practitioners, working with a case manager in the community to coordinate NORA's future care needs. Working together, this team would have developed a longer-term care plan that would be agreed and communicated across hospital and community services and, of course, to NORA and her family. After hospital, access to practical services in the community would have helped NORA to live comfortably in her own home. These would include help with medication, shopping, and minor repairs. This snapshot of NORA's story shows how the development of an integrated care program for older people is a priority for our health and social care services. The team leading this program are meeting and working with health and social care professionals nationwide to plan how existing care can be better coordinated to benefit older people and staff working with them. This seeks to build on a shared local vision that builds a population-based approach to integrated care that is person-centred, planned and coordinated. Find out more about integrated care services at www.hse.ie/NORA.